Well, good evening, everyone. My name is Steve Beck, and on behalf of Louisiana State University's Office of Research and Economic Development, I'd like to welcome you to our first virtual LSU Science Cafe. We are so glad to have you all join us in a virtual format for everyone's health and safety. Tonight, we have the scientists who took an academic research lab and retooled it to help the community fill a critical gap in COVID-19 testing capabilities in Louisiana. But first, we'd like to thank local public radio station WRKF, our proud partner for LSU Science Cafe, for bringing you a forum for exchanging ideas and discoveries in our community. WRKF is giving a stainless steel NPR Science Friday beverage tumbler to one lucky guest. To enter the drawing, there's a link in the chat box, and you can fill out your contact info and mailing address there. We'll announce the winner at the end of Science Cafe. Following tonight's talk, we'll have a moderated Q&A session. Please use the Q&A section located in the Q&A button at the bottom of your screen to submit questions to our panelists. So you're aware, we are recording tonight's presentation so that we can make it available afterwards. We want to thank you in advance for your courtesy and your understanding. So without further ado, I'd like to introduce tonight's speaker. Dr. Hollis Bud O'Neill is an assistant professor of clinical medicine at LSU Health Sciences Center in Baton Rouge and the medical director of medical director of research for Our Lady of the Lake Regional Medical Center in Baton Rouge. Respiratory immunologist Dr. Stephania Cormier, who holds a joint position as the Weiner Chair Professor in the LSU Department of Biological Sciences and the LSU Pennington Biomedical Research Center. She is also the director of the LSU Superfund Research Center and Associate Vice President of Science, Technology, Engineering, and Mathematics in the Office of Research and Economic Development. And an emerging virus expert, Dr. Rebecca Christofferson, is an assistant professor in the LSU School of Veterinary Medicine's Pathobiological Sciences Department. And now it's my pleasure to turn it over to Dr. O'Neill. Bud, thanks very much.
Yeah, thank you for the introduction. And thanks for allowing us to do this. I think this is great. Hopefully we'll be able to tell you all about what we went through and how we kind of got this up and going. And I think that it speaks to the power of community and what we really have here in Baton Rouge and really in our state. And so we're going to start by telling you a little bit of the story about how this all came together and why it all came together and what we saw that told us that we had this need to be able to do this. So it all started about mid-March of 2020, of 2020, when we were, there was this kind of virus thing going around, and we had noticed it because, we had Mardi Gras, and a good friend of mine, Dave Jantz, is a pulmonologist down in New Orleans and at UMC, and he gave me a call. He's one of the ICU physicians. He does the same thing that I do, and I trained with Dave, and he called me one day and he said, "Man, this is a mess. This thing is just an absolute disaster." He said, "Well, I've got people in my ICUs everywhere. They get really, really sick." And he said, "And one of the biggest problem that I see is that I have no idea what's wrong with them. They come in, they're sick. It looks like they have horrible pneumonia. We send a test for them for this COVID thing that's going around, but it's 2 or 3 days before they get a test back. And so I'm spending the first 2 or 3 days of their illness, and I just really am kind of flying in the blind and don't have any idea what's going on with them. And everything changes when I get this test back, and I either know that they have COVID or that they don't." And he said that the big problem is that one of the reasons that this became a big challenge is because people are coming into the hospital with all the same things they had before, but then they have this extra disease, this disease that we think is very communicable. We're having to use personal protective equipment with masks and gowns. We're running out of it. And half of the people that we're testing actually don't have it. And so we're impeding the care of those that don't have it. We're using resources, treating people that don't have it. And a lot of the problem that we have is that we just don't have the testing material for it. And then about the same time, my wife, who is an infectious disease doctor, this was kind of the second week or so of March, my wife, who's an infectious disease doctor, was working with some of the task force here locally on what we could do to begin testing for this test and looking for it, because we knew it was going to be just a matter of time before we had patients with it in the hospitals here in Baton Rouge. And so she was on some community task forces, and they were talking about opening some community testing centers. And one of the people that she had been speaking with was Dr. Joel Silverberg at the Baton Rouge Clinic. And we had seen that the state's lab is really geared for kind of daily activities and kind of routine stuff. Believe it or not, the state doesn't overstaff for times of emergency. And they were becoming inundated with test requests from all over the state. And New Orleans, again, was just kind of going underwater with this thing. And so the question was, how are we going to get tests for this thing and turn it around in a rapid enough way that we can open up our hospital beds? We were already getting patients into the hospital with suspected COVID. We were sending tests, but it was taking from the commercial labs, Mayo Clinic and LabCorp, and some of the bigger tests, bigger labs, it was taking a week to 10 days to come back. The state was overwhelmed. It was taking anywhere 2, 3, 4, 5 days for things to come back. And the other thing that we had seen was that we were running out of just the transport medium, just the swabs and the liquid that you use to stick the swab in to send it to the lab. We didn't even have that available. And so Dr. Silverberg was helping set up a community testing center, and he had asked, is there anything we can do to try to find some of this test media? And I said, well, I'm not real sure. I do some research with some people at the vet school. I know some. They have world-class virology over there. Let's start looking around and let's see if they have any. Because my thinking was, well, they're virologists. They probably have a stockpile of this stuff. Like, they probably bought some of this stuff. They have it around. Maybe we could use some. And in my kind of naive way, I'm thinking, man, if they could just get us through 2, 3, 4 days before we could find some of this stuff, I think we'd be in good shape. And so about March 15th or 16th, I'd gotten in touch with Dr. Cormier, and after some emails that I'd sent around and didn't hear much back, we do some work with Dr. Cormier at the Children's Hospital. And so I got in touch with Dr. Cormier, and that's where kind of all of this thing started, was kind of making that point of contact, because as we'll go through in a little bit, Dr. Cormier has this really unusual ability to, when you ask her a question, if she can do something, she's got one answer. And the answer is, oh yeah, sure, absolutely, yes, we can make that happen. And so that was kind of my perspective on this, that I was seeing it from my end, was that we had this growing epidemic, hearing from friends in New Orleans that this thing was really getting out of hand, that turning around with tests was a big deal to find out who had the disease, and more importantly, sometimes who didn't have the disease. We were running out of test material, test equipment. There weren't enough tests available. The state lab was just getting absolutely inundated. And our hospitals were filling up with patients. The ERs were filling up with patients, and we couldn't move them anywhere because we didn't know what they had. And so that's kind of my perspective on what I saw going on. And so I'll turn it over to Dr. Cormier and let her tell you about what was going on from her perspective during this time.
Good evening. Thank you, everybody. This is a lot of fun. It's kind of different. I don't have a microphone, and I definitely don't have a glass of beer or something from the bar, but I'm excited to be here and happy to welcome you and talk to you about this. Holly, if you can go back one slide. So my perspective on this was a little bit different. I study acute respiratory tract viral infections, and specifically I study the age and how age relates to severity of disease. And I also study it in the context of environmental exposures. And so I have trained actually a lot of fellows that are in the clinical field all over the world. And some of those fellows were actually in China, and they were reaching out to me because they were seeing this disease occurring in their patients' populations and trying to understand the immunology and the immune response and why the body wasn't responding very well to this virus and why this virus was leading to such devastating results. And so that was probably about in November. I started hearing chatter. There's an app called WeChat that they were texting me from in China. And then I had colleagues in Australia and then colleagues in London who were actually letting us know that these things were going to be a problem. I was vice chairing a acute respiratory tract viral infection meeting. That meeting occurred in early February, and there were a lot of attendees who couldn't actually attend that meeting because their countries were already shutting down travel. So the ones that did attend the meeting, there was a lot of chatter at that meeting about this virus and how this virus might be a big concern for the United States, because the United States, unlike most other countries, is not as amenable to regulating our movement throughout the country. And so that was a huge concern on my part. When Bud contacted me, his first questions were, I'm worried about viral transport media. And I said, well, that's easy to make. And so, of course, we can help you make that. And I'll tell you a little bit later why that became actually a little bit more difficult than I had initially promised. And I'll let Becky tell you about the population studies. Dr. Christofferson.
Hello. So my view have always been more population. I like to take a kind of an epidemiological look at things in population medicine and population dynamics of disease. So again, because I work in emerging viruses and there was a lot of chatter, it was November, December. I knew that this, this respiratory virus was going down, but I usually work in hemorrhagic fevers. So it was kind of on the periphery. I wasn't really paying attention because it's not really my thing. In late January, early February, I actually was a visiting scientist at the Institut Pasteur in Paris. And that's when, around that time is when Italy started really getting lit up real bad. And so that's when I think the thought that this could become a really significant global event started kind of sinking in, and we started trying to figure out like, what's the next thing. While I was at Pasteur, the group I was with was actually part of the response. And so they actually got pulled away from, normal everyday programming to start investigating what was going on in COVID. And at that point, I was thinking, well, maybe I should start paying more attention. So I started reading up more on this coronavirus, which is not usually my area of expertise, and still it's not my area of expertise. So I got back to the States right before they shut down my ability to get back to the States. And Dr. Cormier reached out to me and she said, we're just going to make viral transport meeting. We're not going to test. And can your lab help with that? And I was like, sure, why not? I've got people, we can do that. And so then it turned into a zoo after that. So I think we can go into the next slide and show you the timeline. So I think Bud said, that the first presumptive case in Louisiana was March 9th. The first presumptive death, unfortunately, was March 14th. Bud started reaching out, I think you said the 16th, Bud?
Yeah, it was, I started sending out some emails, which we were curious about this viral transport medium. And like I said, my wife was working with some community people on how we can start some community testing. We realized that there was just no availability of this viral transport medium out there. And so I sent some emails to some people, and then we, speaking to our research director here at the Lake, Katie Vance, said, we're going to have to do something. And she said, look, Steph, you got to get in touch with Steph. Steph can make it happen. And so she sent me that text message with Steph's contact on it, which is probably one of the worst things that's ever happened to Steph. She sent that to me on March 16th. And then I was like, well, I'm just going to call her. So I called her and I was like, hey, Steph, this is Bud O'Neill. And I have a little bit of a question for you. And that's when I asked her if we could make this viral transport medium, or if she had any. Again, like I said, I thought that, look, they just probably have stockpiled this stuff somewhere. And again, I thought too, well, let's all we need is probably, a couple of days, maybe a week. And then by then, surely the hospitals will be up and running, and all these other companies that make these diagnostic tests will have us in supply, and we'll be rocking and rolling at this point. And so my first question to her was, can we get some of this? And she said, well, no, we don't have a stockpile of it, but I can make it. And I said, okay, well, that sounds good. How much can you make? And she's like, how much do you want? I said, no more than maybe a couple hundred to a couple thousand of them, or something like that, maybe. And she said, okay, yeah, we should talk about this a little bit more. And so, because again, looking and seeing what was going on, it was clear that this was going to become a problem. And so, and I'll never forget this too. Driving, this was about the time that we were talking about maybe, kind of hunkering down, going on isolation, driving around Baton Rouge, watching people buy all their beer and everything they needed for the St. Patrick's parades. I was thinking, oh, this is going to get really ugly. And so then it came to light that our hospitals were filling up at about the same time, that that day. And so it was actually the very same day, March 16th, speaking to, again, Dr. Silverberg and my wife about this. And we were like, it's not going to matter if we have transport medium. That's going to be awesome. But it's not going to matter because we're not going to have a place to send it. Nobody's going to be able to run this test. And so I said, Dr. Cormier counts viruses, finds viruses, detects them, counts them, works on vaccines and the secretions of children. I bet, running a PCR to find this, just to tell me that the virus is there or not in an adult shouldn't be a big deal. And me kind of being the, I guess sometimes less than sophisticated ICU doctor, I'm just like, oh yeah, absolutely, we can do something like this. And so I called Dr. Cormier back and said, hey, remember we talked about this transport medium? And she said, yeah. I said, well, the good news is we probably don't have to transport it very far. That's the good news. So now the bad news is we probably need somebody to run the test. So do you think that you could figure out how to do this this PCR in your lab? And she says, like she always says, well, sure. And so that's really how it started. Just a simple question to a scientist from a clinician saying, we've identified a problem. We need a solution. It started out as just viral transport medium and very, very rapidly evolved into something much bigger, which was we need tests and we're going to need them in a bad way. I don't think any of us predicted how bad of a way we would really need this. And so that was kind of my first contact. And then I'm going to let Dr. Cormier tell you a little bit about some difficulties we found with this whole thing that was a little bit new terminology to the clinician, which is this whole concept of the supply chain. Right.
So Bud reached out to me, and within 3 days of Bud reaching out to me, we had figured out how to actually create the viral transport media. And for those of you who don't know what a viral transport media is, when you have the test done, that swab is actually put into a liquid solution. That liquid solution is the viral transport media. And the viral transport media is not very sophisticated. It's something that does not harm the virus and allows the virus to stay intact until we get it. And it has some antimicrobials in it. So it has some antibiotics, it has some antifungals. So during transport of that specimen to our lab, other things don't start to grow in that transport media. So when Bud first reached out to me, we started looking for all of the reagents necessary to create that viral transport media. And while the media was fairly easy to find the reagents for, the swabs became a limiting reagent. And so on the 13th, we started looking for things. And on the 16th, every swab in the entire United States had been purchased or made unavailable. And Holly, if you want to change to the next slide. And so at that point, I started reaching out to colleagues all over the globe. I was contacting colleagues in Australia to get swabs if they had swabs. The swabs had to be a particular swab. It's sort of like a Q-tip, but it has to be there has to be no wood on the Q-tip, so the handle has to be polyester or plastic, and then the swab itself has to be polyester because the cotton or the wood would actually inhibit and kill the virus, and so we wouldn't be able to detect the right quantity. Australia didn't have swabs. China had swabs. China sent me several cases of swabs. However, they had to send it in weird ways. So they were worried that it would get stopped at customs, and so they would send me small packages of swabs at first. And so I'd get these small packages of swabs that would show up on my doorstep at the house until we were done testing. The fix for that was eventually when we actually had to have supply chain help. And that supply chain help actually came from senators. Senator Cassidy's office and Senator Kennedy's office worked with us to try and relieve those supply chain issues. And that started happening around the 17th. So Bud contacted me around the 16th. We were starting to get reagents to make the viral transport media. We realized that the viral transport media is not the only problem. And I started reaching out to people across LSU's campus to find out if there was anyone who could help with the testing. That's when we talked to Dr. Christofferson. We talked to and she was willing. She also said yes. She may be sorry about that yes now, but she said yes. And so she started working on biosafety protocols while I was working on creating and packaging viral transport media for the hospitals. Dr. Christofferson.
Yeah, so we didn't do this willy-nilly. There are certain protocols you have to follow and rules you have to follow when you're handling infectious material. We do it all the time. That's our job. We do it at the vet school. We have an entire department that is basically infectious disease, some of them who are working on COVID now. And so we had to go through all the regulations that we're familiar with, which was writing of biosafety protocols, having them reviewed by Heidi, if you want, Holly, if you want to go forward. But so we submitted and had our biosafety protocol approved by the BSL-3 committee. So we have at the vet school a high containment virus lab. It's not just a virus lab, a high containment biosafety 3 lab. And that there are 4 biosafety levels. There's 1, 2 is what most of us work in on the day-to-day. 3 is where you have to have negative pressure, and you have to have a HEPA filtered exhaust system. 4 is, you're doing stuff for the military usually. There's a couple around the country, not too many of them, but 3 is still relatively high containment. I've been in high containment laboratory now for over 10 years. And so while we could have done this at a lower biocontainment level, because of not only safety reasons and because that's what we're used to and it's not a big deal for us to do it in my lab, but because of the way we needed things to flow, we started to think about doing this at a BSL-3 level. So we had to get approval by that committee, which we got in it was an accelerated pace. And so we were very grateful for that. And then we had to actually submit that protocol further to the entire LSU biosafety committee. And again, that was done with amazing speed and just, they were happy to do it and it was amazing. So we got our biosafety approvals, which means they went through and nitpicked and made sure that we knew exactly what we had to do and what was acceptable and what was not. And then we had to do something that none of us were, or at least Steph and I were not, used to, which was federal regulations for clinical diagnostic labs. We learned an entire new vocabulary, I think.
Yes.
But before we go into that, I do want to say that from my end, we were working on the RNA extraction. That was my baby at that point. Because I was working with the system, I have been working with the system that was CDC approved for this test for, forever. At some point, we did experience another supply chain issue with those, with these plastics that we needed. And we had help from not only people from across LSU's campus, so Dr. Balasuria at the Louisiana Animal Disease Diagnostic Lab at the SVM helped us out, but I reached out to colleagues in Wisconsin and Iowa, and they reached out to colleagues to try and help us fill the gap until some person could find a boat, because apparently a boat went missing. So, it was stressful, but it was very cool to see not only how in the Baton Rouge community science came together to fill this gap, but Steph's talking to people all over the world and I'm talking to people all over the country, and no one said no. Everyone was like, I can't do it, but we're going to find somebody who did.
And I think
and I just want to add to that. So when I reached out to my colleagues in Europe, when they couldn't actually help me with anything, they put me in touch with companies who could send us stuff.
Yeah, and I think that from our perspective, when all this was going on, this ball had started rolling, and then at some point kind of looked up and said, okay, so I guess we're really moving forward with this. We're actually going to have to open up a diagnostic lab. Where are we going to get the patients? Where is this going to come from? Because we knew that the hospitals were becoming overwhelmed. And so we began to engage, pretty early, Our Lady of the Lake and Baton Rouge General, just speaking with the CEOs there, Scott Wester and Eduardo Tenuero, to try to figure out exactly what the hospitals needed and what could we do to help. And so we had made the commitment as we were doing this, that the sole purpose of this lab would be to decompress the hospitals. The hospitals were becoming overwhelmed. They were bursting at the seams with with suspected COVID patients, not confirmed, but suspected COVID patients. And like I said, every couple of days, a couple of results would trickle in. The state was just, I mean, really working 16, 18-hour days, turning things over, but they were overwhelmed with, New Orleans and the rest of the state. And so we went to them and said, what can we do? And the answer was, if we can get some tests back just any faster, everything helps. And so our commitment was to decompress the hospitals in the area, starting with Our Lady of the Lake and Baton Rouge General, because those are the two major hospitals in the area that were going to feel the brunt of the blow. And they were extraordinarily supportive.
Yep.
They came and visited us on site, looked at the lab, made sure that the hospitals would be able to support the lab, that they agreed with kind of what we were doing. They offered, personnel support, regulatory support, because this acronym you see up there, CLIA, we had never really dealt with. Again, as an ICU doctor, I'd never dealt with it. I think as researchers, Drs. Christofferson and Cormier had never dealt with it. I knew that they were formidable, that they had a high bar. I don't think any of us realized exactly what that meant, because for me as the doctor, I'm like, look, I just want to know, is the virus there or not? Just tell me, please. Not thinking about all of the process that goes not only into finding the RNA for the virus, but also, the regulatory stuff. And there were many reports, I'm sure everybody read the news about it, of these labs that would just pop up. And all they wanted was your money, and said that they would test for it, and it may or may not have a valid result. And so I think that one of the important things that we saw was just how incredibly helpful the healthcare community was, hospitals to Baton Rouge Clinic and all the local providers. We really felt one of the things, we became bogged down at certain points, but we really felt that we had the backing of the entire healthcare community.
So I just want to add in, because I know that we've got a short time frame here, and I don't want to step on Dr. O'Neill. But Dr. O'Neill, I wanted to make sure that we point out that CLIA process. So one of the big things for the CLIA approval process was actually identifying a medical director for the lab and a laboratory director. And Dr. O'Neill actually called and contacted a lot of people and was told no by a lot of people. And there was one person who actually stepped up to that plate, and that was Dr. Bev Ogden over at Women's Hospital. And without her and her team, that CLIA process wouldn't have gotten done. And we're going to have to move forward at a little bit faster pace. Just going to mention that. Okay. So
we submitted our FDA application. So the week prior to this, I mean, from the 13th on, we were just we were working every day, all day, because we had to validate our machines. We had to validate our people. We had to fill out a whole bunch of tables. And so we finished all of that in the afternoon of March 23rd. And Bud was like, you want to start testing? And so Holly, if you want to click on that evening, when we were legal, we started testing. And so we started testing March 23rd, and we ran through May 13th was our last day. So I don't know if we're going to go next through.
So we'll go real quick through this. So to give you an idea of what we actually had to do to get the test done is everything that replicates in our body is made of nucleic acid, so genetic material. That genetic material is also present in viruses, and the virus needs that genetic material to replicate also. The reaction that we do to actually detect virus detects that genetic material or that nucleic acid. And we do that through an amplification process where we amplify that genetic material in a machine which we call a light cycler. So on the right, you're actually looking at Eduardo the Great, and it's called Eduardo the Great because Eduardo, when we were having trouble purchasing this through regular channels, put down the money to buy this and got this to us in like under a week's time. This was the last light cycler in the United States at the time. And so we got this light cycler, which would allow us to do like 384 reactions at a time, greatly increasing our output so that we could help the hospitals who were in desperate need at this point. But Dr. O'Neill?
Yep, I think you can move on to the next slide, I believe. So one of the things that we do and I don't know who all has been tested for this disease, but one of the things you do is that you have a nose, that's a nose right there, and you stick a swab way up the nose and you tickle the brain. And we tell people, like, okay, if they start having numbness in their leg, You got there. And so, as you do this, you have to stick it back there, and you actually have to grab some of the virus. Of course, obviously you can't see this. You have to grab some of the virus and you hope that it sticks to that swab. And so, that's kind of the first step. And believe it or not, patients don't love this, and it results in some arm wrestling matches between the patient and the nurse sometimes, or the doctor doing it. And so then you take that swab that hopefully has some virus on it, and you stick it into this tube here that has that viral transport medium in it that Steph talked about making. And so she made this, and Steph, how many of these did you make? About 5,000 or 6,000 of these things?
Oh, we made more than that.
Yeah.
we made about 8,000 of those things.
Yeah, so my couple of hundred, doing this for a couple of days with a couple hundred viral transport medium turned into 8,000 of these things.
But you know what? I didn't listen to you when you said a couple of hundred. I heard enough for 5,000.
So anyway, so then hopefully you've gotten some of that virus there, and you've put it in the tube. And so I'm going to let Dr. Christofferson say what happens next.
So when you have virus in this tube, you take a pipette in a biosafety cabinet, safety first, and you remove a subset. So here it was 50 microliters, which is a really small amount, and you put it in an activation buffer. And basically that pops the virus, and the virus is dead at that point. So from then you take it, and we go through a series of washes. We use a magnetic bead reaction, and then we go from having dead virus in some liquid to having the viral nucleic acid, which is what you need for the next part. And so at that point, that's when my lab stepped in, and my lab was actually in charge of amplifying this viral genetic material, or the genome of the viruses. So what we would do is take the RNA, which was the nucleic acid from the virus, and then we'd put it into a PCR or an amplification mix. And on the next slide, in that amplification process, there are multiple cycles that the genetic material goes through. And what you're watching is just sort of an animation of how that genetic material is amplified. It's amplified on a logarithmic scale, and it's done over at least 40 cycles. And so you go from a couple of copies of a viral genome to millions of copies of viral genome. Each of these genomes are actually tagged with a color molecule, and so we have a light that can read it. It's a laser, and the laser detects light from these amplified products and gives us the amount of virus that is actually present in each sample. Next.
Yeah,
now, there are limitations, Dr. O'Neill.
Yeah, this just talks a little bit about some of the limitations to every test, and not every diagnostic test, not just this one. But, again, maybe you didn't get enough virus, maybe something happened with the reaction. You see there are many steps along the way. And, the FDA made us go through a series of steps to prove that we actually could do what we said we did. And lo and behold, turns out that Drs. Cormier and Christofferson know what they're doing pretty good. And we were able to pass all the FDA's tests and get all of the developmental work that we needed done. You can go on to the next slide. And so one of the things, too, that I think is important is that when the sample arrives in the lab, it arrives as a bag with a piece of paper on it that has the patient's name and then the tube. And you hope that that piece of paper is the same patient that is on that tube. One of the things that gives a little anxiety to the doctor that was doing this was, okay, yeah, that the science it requires a ton of skilled people to do it. But then we would also have to take those papers in that tube, separate it, put that paper into a computer system, number the paper in the tube with a unique number, so that at the end of it, when they're finished and Dr. Cormier reports out the results, we make sure that result actually belongs to that patient. And so that was a pretty labor-intensive part, and we had support from nurses, from the research staff at Our Lady of the Lake, from staff at Baton Rouge General. We had one of our chief residents, Dr. Morgan Walker, helped us with this and really led it. Dr. Jonathan Schroeder, who is a primary care physician for HIV positive patients, came and spent. He would sit up in the morning and do accessioning, see patients all day by video visits, and then come back at the end and then report out results. And he got really good with time and date stamps. He could kind of double barrel it. And so we got it down toward the end that we could report around 100 results by about 2:30, 3 o'clock, and we would put them all in a in our electronic database, and we gave the hospitals login credentials so that they could see that database. And then we would then have to go through this wonderful piece of technology called the fax machine to get the results on paper over to the hospitals.
Yeah, so we coined ourselves the River Road Testing Labs, and the whole thing would take around, depending on the day and how many samples we had, it was usually somewhere around 10 to 12 hours a day. The BSL-3 and the RNA extraction part would take, a few hours if you included, freeze thaw is really the thing that takes the longest. Unfortunately, you can't speed that up. And we would come out and give it to the the PCR group, and that would take, another
couple of hours.
then,
Sometimes 3, depending on.
And then the resulting, which I know I managed to get out of the resulting. So
well, Becky came in the morning. She did the morning shift, right?
Yeah.
The resulting stuff could take forever. And in fact, at one point, I think there was someone who actually fell asleep at the fax machine, but we're not mentioning any names.
I don't know who that would have been.
I think he let me go home at 2:30. But so one day I walked in and there was a fax machine sitting on the floor and a high-speed scanner for me to install.
Yeah.
And so once we got that involved, the resulting actually took a lot less time because we were able to use a HIPAA-compliant fax server that was online that didn't require us waiting forever for a single fax to go through or hundreds of faxes to go through a night.
And we put it on the floor so you could fall asleep and not hurt yourself.
Right, exactly. You could just sit down next to it.
Yeah. All right, we can move on, I think, to the next.
Oh, Lord, yeah.
Okay, so the River Road Testing Lab, as Dr. Christofferson said earlier, ran from March 23rd to May 13th. We created over 8,000 testing kits. That's the viral transport media. That viral transport media was pipetted or aliquoted into tubes at 2 mils each. Each of those tubes were labeled. A swab was put in a package, and that was packaged into a Ziploc bag with a biohazard bag, and that was all sent out to various hospitals. We ran over 3,857 individual tests. That means that's a per patient basis. So we ran almost 4,000 patients over that time frame. And what was really interesting about the CDC's original test is that you had to run 3 reactions per patient. And so that means we ran over 11,571 PCR reactions. So that's a lot if you've ever done this before. Our overall infectivity rate or positivity rate was 33%. And the range of patients that we actually covered were from 1 day old to 99 days of age. Next.
Yeah, so we, again, we focused on Baton Rouge hospitals, Baton Rouge and Women's Hospital. During the time, we also were able to help out the first responders and do some testing for them. And then some of the surrounding hospitals, as far out as Lake Charles, also going east to St. Tammany Health System, we were able to test for some of those. We also tested various congregate settings, be it nursing homes or jails or anything. We tested, we did anybody that we thought needed to help, we needed to help. And we focused on hospitals, congregate settings, and healthcare providers. And that was our goal. And I think we were able to achieve a lot of that. So you can move on. And I think real quick, we can let Becky take just a second and say what that meant to the healthcare kind of system in general.
So I'll let you speak to the morale, except that my baby cousin, who's over 6 feet, Ryan, works in healthcare, and I would get texts every now and then that says, "Y'all are helping us so much, and the morale is up." And I never thought about morale being an issue, so it was an interesting thinking outside the box for scientists who tend to stay, in the laboratory setting. But one of the things that I do, because I'm a nerd, is math. And so we wanted to sort of quantify in some way the resource allocation. And so Dr. O'Neill and his wife, the other Dr. O'Neill, were estimated that for every patient that was negative and over only 33% were positive. So that means most of the patients that we tested were negative. And those were the patients you could move out of the ICU and save, the masks that were in really, really short supply early on, which led to sort of the confusing message of don't wear a mask. It was not really don't wear a mask. It was kind of let's save the mask for healthcare. So we estimated that we saved upwards of almost 12,000 sets of PPE. So that includes gowns, that includes masks, that includes, what else? I can't remember the other thing.
Gowns, masks, gloves,
right?
Face,
nurses.
Yeah.
So and here we kind of also estimated, would we have had an impact if? So the 90%, we handled 90% of the hospital's ICU patients for the period of time that we're looking at. But even at a lower index of 50 and 25%, it still would have made, a difference to have that shorter turnaround time. And that was the whole thing. Our turnaround time from the time of collection to the physician getting the results was under 2 days, and at most was 3 days, which was significantly shorter than what other labs were able to do for the ICU. And so at that point, the turnaround time was really the crux of the resource saving.
Next.
I think that's.
Yep. So
this is our team.
This is our team.
They're amazing.
They were amazing, and without them working long, hard hours, this would not have been possible.
Nope.
Not pictured here is Dr. Ogden, who I think was actually taking the picture.
Yes, she was.
But from left to right, you're looking at Dr. Luan Vu Hanley.
Yep.
You want to introduce your people?
Hanley Maiden is my senior grad student.
Pratiti Chowdhury is my postdoctoral fellow.
And then I think An's behind her.
An was the person who kept us all organized, fed, and sane.
Yeah, we were fed really well. The hospitals treated us good.
And ORAD and other people, all bought us food.
Yeah, and then Chrissy Walsh is my graduate student in my lab, and then there's you.
There's me, and then there's Thea Souffle.
Yeah, she's a research associate in my department, and then there's me. And then Abigail Fish, who used to be in my department, and then she's now at Environmental Health and Safety. And then Eric Turner, who actually joined my lab approximately 2 weeks before all this started. So trial by fire for Eric. And then not pictured also is Dr. Schroeder and Walker, and then Bud and Katie, and then the small army of people. So
yeah. Next slide. And we really have to send this would not have been possible without the Baton Rouge Area Foundation and the Baton Rouge Health District, which I'll let Dr. O'Neill explain who those people are. But they were responsible. We volunteered our time for this, and the reagents were actually supported and paid for by the Baton Rouge Area Foundation and the Baton Rouge Health District. And without them, this would not have been possible, and we could not have done it. We had a lot of governmental support all the way from the governor to Senator Cassidy and Senator Kennedy. We had a lot of LSU upper administration support, which was fantastic the entire time. And I remember walking into Sam's office on that Friday saying, "Sam, I think they need my help," and Sam just saying, "Go do what you got to do." And that was a very heartwarming experience. We had other supporters, including people at Pennington who were helping us with aliquoting most of that viral transport media. And then without our VWR rep, we wouldn't be here either. But do you want to say what the health district is?
Yeah, the Baton Rouge Health District is kind of I would say a loose organization of hospitals, clinics, healthcare leaders in the city. And the idea is to really bring healthcare to kind of the community and community-wide setting so that we can all work together. And I think that this was a perfect example of Baton Rouge General, Our Lady of the Lake, Baton Rouge Clinic, state government, local government, all working together to make something happen and bring high-quality care to our patients in a time of need. And I think that that's what this is this was the opportunity for academics and clinicians and anybody who was willing to pitch in and do it. The labs at the General and the Lake stuffed a lot of kits and put a lot of stuff together. So labeled a lot of things for us. So it was truly a community thing.
Yeah. And the last slide. We'd also like to thank the other people who contributed to the foundation, and the foundational monies were actually used to make the viral transport media and to run all of these tests. So it bought all of the reagents. So we would like to thank all of these families who actually contributed to that foundation. And we'll be happy to answer any questions.
Okay, thank you.
I'm sorry we went over.
That's okay. That's okay. Thank you all for what you've done. This was really absolutely fantastic. We have some great questions, and we'll just start. So Richard asked, I have been modeling the case in Louisiana and have tried persuading politicians to take action since the beginning, but have been ignored. How do we get politicians to listen to citizens when they are not even listening to epidemiologists? And I'll leave it at that. So who wants to take that one?
I will say that I would, it's been an interesting time to be in epidemiology. And I would say that, it's a very complex question, which is way above our pay grade. But I would say that the politicians are juggling not only the biology of the question, but also the sociology and the economics and all of these things. And so there's probably moving parts of this system that we probably don't quite understand the complexities of. And so, other than that, that's a higher level question.
Yeah, and I would say this with regards to that is that this is a difficult virus, and we are faced with it many times, and especially from younger people. And then there are some other people who would say, I'm okay if I get the virus, whatever, I'll take my chances with it. And I get that. I understand that. As a physician, humans have free will and we can do that. But what I ask for people to do is wear your mask, wash your hands, don't touch your face. And the reason is that I'm okay for people taking responsibility for their own decisions they make. I'm not okay for people taking responsibility for other people's lives when they don't do it. And so when you wash your hands, when you don't touch your face, when you wear your mask, when you do all these things, okay, I get it. You're okay if you get the disease, but the man, lady, child, grandparent next to you might not be. And so we're a community. We should take care of ourselves. We should take care of each other. And if you want to go do what you want to do, I'm not going to speak to if that's right or wrong, but do the things that you can do to protect other people. It's not all about you. It's about the community.
Yeah, the word altruism has been in my vocabulary a lot this week, and we have to invest in our own altruism for our community.
Yep.
Absolutely. We have an anonymous question. Do you think that vaping aerosol can spread COVID-19? So actually, Dr. Cormier, what do you think about that?
You're on mute.
You're on mute. Sorry. I do think that, yes, vaping or cigarette smoking is going to spread it because you're actually expelling a lot of aerosol when you're smoking, either smoking e-cigarettes or smoking regular cigarettes. The other problem with vaping is that it's actually going to exacerbate the disease, causing enhanced lung injury, and that's going to lead you to worse clinical symptoms. In addition, there's some data that suggests that it actually may increase susceptibility to infection. So you can get infected with lower amounts of virus.
Okay.
Pulmonologist is going to tell you that vaping is probably bad for you anyway.
For you to begin with, right? Yeah.
And the other thing is it's very funny. It's hard to vape with a mask on. And so if you want to take responsibility for your own health, vape away from everybody else indoors in your own house.
Mm-hmm. Yeah.
Wear a mask when you're out in public, and you can't vape through the mask.
That makes good sense. Fabio Del Piero asks, or he writes, "Thank you for your help to the community."
Hey, Fabio.
Obviously, you acted fast, efficiently, and with scientific knowledge. Regarding prevention, what could have been done better at Louisiana level and at the national level, and what should we be doing from now on?
I think Dr. O'Neill answered most of that.
I think, though, from a higher level perspective, we could see it coming. And it's not that we could see it coming from November or from December. There have been people studying zoonotic diseases and emerging viruses for years and years and years who have said it's only a matter of time. And there have been numerous people who have had, efforts to go and find these types of viruses and track them down and really kind of determine what's the next big thing? I think, and I'm a little shocked actually that we were as a country so grossly unprepared for something of this magnitude. If it wasn't going to be coronavirus, it was going to be something else. And I think that our ability to not stand up labs quickly to sort of fill the gap was surprising. And I think going forward, that should be a priority, is to sort of have the capability to quickly react to things on a large and small scale, and to sort of make, Bud had a great idea. It's like the U.S. Armed Forces have a reserve force. We should have a reserve force of willing and able academic labs, or even, commercial labs who are capable of making a network. I mean, I tell people that science right now is working like a bunch of, old ladies from rural Louisiana. They're all on the phone. None of this is being done except through email and through Twitter, and everybody's talking to everybody else because it's all so new that it's a network. And that whole networking thing is what's really going to help us stand up the next time.
Yeah, I think in times of crisis, Americans have always been very creative. You think in World War II, we used housewives because of their dexterity to rivet airplanes together. We've always come up with a way. And I think that in this situation, we use world-class virologists to solve a problem, a very simple problem in virology, which is, can you run a PCR and tell me if a virus is in this or not? And so we weren't asking for, an 11th grade student to do, quantum physics. We were asking for experts in their realm to do what they do every day. And I think that one of the things that we need to do as a country, as a state, as a local government, whatever, is to allow our talent and have mechanisms for our talent to be able to do what they need to do. I think that that's always going to be something that we can look back on.
Actually, yeah, that's actually very important, because the certification processes were actually, the licensure to do these tests was actually waived by the state. And without that waiving, then we would have had to have licensed laboratory technicians do something that we do every day on a daily basis in our sleep, which made, as a molecular biologist, that made no sense to me whatsoever. I was doing PCR before PCR was actually a machine, and before the Nobel Prize was given out for PCR. So to have somebody tell us that, it was amazing.
It was really good how they worked with us to sort of recognize that we still had to go through validation process.
Right.
We had to pass competency. So it wasn't like we threw all the regulations out.
No.
And actually the state and some of the federal agencies worked with us to sort of, not just us, but with labs around the country to sort of adapt.
Right. And the state was actually very instrumental in our validation process, because they had to actually supply the samples that we validated with.
Mm-hmm.
How we could have slowed this down moving through the U.S., I don't know, except to say that we could have shut it down sooner, and that would have been the only thing we could have done. But shutting it down, even when we shut it down, didn't work very well.
Right. And I think that
just a mobile people.
Right. And if you look at Louisiana, this probably started from somebody coming to Mardi Gras.
Right.
And I don't know how you would have shut down Mardi Gras. I think that would have been an impossible task. And I'm not saying we couldn't have done better. There are certain things that are very difficult to do. I think responding more quickly could probably have been done. But I also think that even now, today, it's still spreading. It goes back to the same thing. Wash your hands, don't touch your face, wear a mask, take care of each other.
Yep. So
we've had a couple of people ask why the testing has ended. From your perspective, what is the reason your act has ended? And
well, so I'll start.
Okay.
Because we were only meant to be a Band-Aid until the hospitals came online, and part of that is because we have full-time other jobs, and also we have families, and I'm not exaggerating when I say we worked straight through over a month. 7 days a week, 10, 12 hours a day. We were exhausted. We were only 10 people doing a gargantuan amount of work. And I'm also not exaggerating when I say I didn't see my children awake for a month. And so it was hard. It was grueling. We committed to it, but we were only ever supposed to be a Band-Aid because there's no human way we could have kept going. The other reason for that is that we have at the vet school shared lab spaces. And so the BSL-3 is not my lab, it's a community lab. My other lab spaces are shared. And when we reopened for research and we started having the other graduate students and the other programs come back in, it wasn't possible to kind of have this sort of machine working in that space. And we had to let graduate students who were still dependent on, all of this to get back to their own regularly scheduled programming.
Yeah, and I think that when you look at those regulations that CLIA has, there's a reason they have them, and they have them for this reason, for diagnostic laboratories to be good diagnostic laboratories. And as Becky said, we were meant to bridge the gap until the diagnostic laboratories could come online. And so it was never our intent to be a permanent diagnostic laboratory. We aren't set up for it. We don't have the personnel for it. We don't have think of the database. We have a database now of, almost 4,000 patients that we can go back and search through, but we're not set up for that. And so I think that, recognizing that those regulations are there for a reason, there was a time that I think we filled a need, and there was also a time that we needed to get out of that and let the professionals do their job.
Yep.
So Arne van Gemmert has a very interesting question. If the virus mutates, will the test become less accurate? What's the breaking point? When does the test not work anymore?
I'm going to let Dr. Cormier take that one.
Yeah, so the test actually relies on recognizing very specific genetic sequences. And so if the virus mutates within those sequences, then we would be less able to detect it. Now, what the CDC built into most of the approved tests is that you don't just look at one sequence, you look at multiple sequences. And so there's some redundancy. You're not looking at the same sequence, you're looking at a different sequence. So if this one mutates, you can still see this one. And so there's some redundancy in the test to be able to detect whether or not the virus is there. And so the tests are actually pretty good with doing that. Now, over time, over years, it's probably going to change, but hopefully we're adapting as those changes are occurring.
There's no evidence right now that there's significant change up to this point. There's been some, but there really hasn't been a really big mutation event.
Right, and then the sequences that are actually chosen for detecting the virus actually are sequences that don't change a lot on the virus.
So this seems like a very technical question. How do the magnetic beads help in separation of the genetic material of the virus?
So RNA actually is charged, like it has a charge on it, and
negative.
Yeah, it's negative, and yeah, it's just they stick to the beads, and the beads take it through several
positive.
Yeah, and it's like magnets, and they take it through several washes, and they just, at the very end, they release it. I know. So it works exactly like a magnet. So it's like the RNA is actually the negative pole, and the beads and the reaction are the positive pole.
Right.
Okay. So we're going to ask one last question, and it's kind of a pretty basic one. What's next? Where does the River Road Testing Lab go from here? What do you? We know that you've closed the operations in part because you were meant to be a stopgap. But what I really want to ask from this kind of tease out from this question is, what have you learned about your ability to respond to this pandemic, and how you could respond in future, whether future waves of the pandemic or future pandemics or future situations more broadly? What are the lessons that you've learned here, and what is the takeaway for our audience in terms of what you was able to engage in this activity?
So I can start some of that. I think the biggest thing we learned is you need support. You cannot do this alone. You can't do it as just an academic person. You can't do it as just a clinician, and you can't do it as just even a testing lab. You need the support of the medical community, right? The medical community actually drove the support in this case, But without like Dr. Ogden coming in, we wouldn't have been able to even get the CLIA license. You need the support of an organization that is quickly able to mobilize money, which Edgardo did, which was tremendous. Baton Rouge Area Foundation did, which allowed us to buy reagents before the reagents were all sold out. And without that support, we wouldn't have been able to even order stuff and be able to help the hospitals. And they were just more quickly able to mobilize funds to set us up than any other way. And so I thought that those were, from my perspective, those were the tremendous areas that you have to look to and make sure that those are set up if you're ever going to do this again. Dr. O'Neill.
I think for me, what I learned from this, and where I hope that the River Road testing lab goes, other than maybe Tin Roof getting us a beer named after us, but
Tesh 31.
No, that's right. But no, I think that in all honesty, what I saw out of this was, I think we accomplished something that was fairly extraordinary, and I say that because when I look back at it, I think that the whole was greater than the sum of the parts. And I think that what I mean by that is that we are in Baton Rouge, Louisiana. I don't know that anybody knew that the vet school housed world-class virology. I don't know that anybody knew. I don't know that many people think of Our Lady of the Lake being, the largest hospital in the state of Louisiana, of Baton Rouge General being one of the most well-equipped hospitals in the state of Louisiana with almost every service that you could need. I don't think that many people know about the Baton Rouge Area Foundation and what they can do, the Baton Rouge Health District and the power that's in the community there. And so what I would like to see, and what I hope came of this, is that we all saw what the power of our community can be, and that we continue to integrate and support higher education, because when you need higher education, that's who produces the expertise and the skill and the knowledge that we need. And that's what's going to drive us to be successful in the future. And so what I hope is that this begins, a series of relationships and collaborations that turn the Baton Rouge Health District and the Baton Rouge community into a world-class leader in health sciences. I think that we have the expertise to do it. I think that we have all of the pieces and parts. It's going to take some special people to put the puzzle together. But what I hope this grows into is, in 10 or 20 years, when we look back at this, we say this is where it started, and this is where we've created kind of a world-class healthcare system and medical system in Baton Rouge, Louisiana.
Yeah, so they said that very eloquently. So I'll just add that I learned two other things. One, that my husband is a saint. And two, that the next thing we're going to do is take some time. I think we have several places we want to go on vacation, right? That's what the next thing is. But as far as next steps, this turned into we've already kicked around research ideas, which is kind of our bread and butter. And it really, I think, is going to turn into a long-term collaboration with Bud especially, and across our three kind of disparate disciplines, but they've turned into some really interesting questions. So
yeah, the only other thing I want to add to that is, since Becky brought up her husband, I should bring up that this was not possible without the help of my Aunt Sandra and Uncle CJ, who walked my dog every night, because I could not get home in time. And then sometimes I brought her and she was in the car until like 2:30 in the morning.
Well, thank you all. Thank you, Dr. Cormier, Dr. Christofferson, and Dr. O'Neill. This was a great presentation, but more importantly, the work that you did undoubtedly saved lives in Baton Rouge and in Louisiana in general. And it's really a remarkable thing that we were all able to come together and that you were able to provide this important service to the community. So on behalf of our community, thank you for everything that you've done. This concludes our edition of our first virtual Science Cafe. By the way, the winner of the Science Friday coffee mug is Carl Motzenbacher, and Carl will be in touch with you, or WRKF will be in touch with you to get your information and make sure that you get the mug as quickly as possible. Again, thank you all for attending this Science Cafe, this virtual Science Cafe. I know that we will be, we're already planning for the next one at the end of July, and we hope to see you there. Thank you all again. Thank you very much, and we'll see you then. Bye-bye.
Bye. Thank you.
Thank y'all.